All right, good evening, everyone. Welcome to our monthly AABIP webinar series. I'm Ara Chris. I'm coming to you from Loma Linda University from Southern California. And on behalf of my co-moderator, Dr. David Shaw from Harbor UCLA, we're excited to bring you another highly anticipated presentation by one of our esteemed colleagues. But before formal introductions today of our topic and speaker, I'd like to review a few housekeeping matters as usual. First, everyone, please note that this webinar, as before, will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education tab on the front page. Next, a couple of important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and don't necessarily reflect those of the AABIP. Now, for those of you who have joined us before, you probably already noticed that we are using a new webinar platform. We do think it is user-friendly and hope the transition will be seamless for everyone. But since this is our inaugural session, please bear with us should any glitches arise and let us know how we can make the experience better. During the webinar, please note that you, as the audience, will be muted, and so you will not be able to verbally interact with the speaker or other participants. Now, however, to ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking on the chat icon located in the toolbar at the bottom of your screen. And also make sure that your chat is set to direct to all panelists and attendees so that we, along with the entire audience, may see your question and or comment. Now, please bear in mind, we will keep track of the questions as they come up and address them toward the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time during the hour. So without further delay, I'd like to turn things back over to Dr. Shaw for our formal introductions today.
Thank you, Ara. As mentioned, today we are very fortunate to have Dr. Angela Selzer. She is an assistant professor of anesthesiology at the University of Colorado in Denver. And today she's going to be presenting on the topic of preoperative evaluation of the preoperative anesthesia evaluation for interventional pulmonology procedures. And obviously this is highly relevant to the practices that we have. So thank you very much, Angie, for joining us today. And we'll go ahead and turn the floor over to you.
Thank you, guys. Thank you so much for having me here today. I'm really excited to have this opportunity and looking forward to hopefully an interesting discussion at the end of the talk. So please think of questions as I'm going along. I'm going to get really sick of listening to myself talk and want to hear what you guys have to say. So the topic of my talk today is preoperative anesthesia evaluation for IP procedures. I am an anesthesiologist who subspecialized in thoracic anesthesia, and through that track ended up doing quite a bit of anesthesia for interventional pulmonology procedures. So that is an interest of mine that I have. And also here at the University of Colorado, I'm the medical director of the pre-op clinic. So we evaluate primarily surgical patients, but procedural patients as well in our clinic. And I'm going to go over the basics of preoperative evaluation and also more specifics that I think are going to be relevant to you all and your patients. So first off, I have no conflicts of interest to disclose. And the first thing I'd like to address, and when I spoke at the conference last August, the question that I got most commonly from pulmonologists was, why don't the anesthesiologists at my hospital want to give anesthesia for the procedures I'm doing? And I don't know if you all have had that question in your mind, but I just wanted to address it at the start of the talk. So if you look at this is a picture off of our IP fellowship website. You all may recognize that gentleman. Two people over from the right side, Dr. Musani, a really wonderful human being and a great pulmonologist. And I really enjoy spending time with him. But I do have to say that there's reasons why people would look at this picture and really sort of dread this scenario. And I'm going to just describe that to you real fast. So the first thing that makes anesthesiologists nervous about these type of procedures are the fact that we have to share the airway with you all. So the airway is typically, unless we're working with sometimes ENT surgeons. But in general, the airway is our deal, and we don't want to share it with anyone. We want to have complete control over it. We have ownership issues, and we don't like sharing. And so sharing the airway is something that just makes anesthesiologists from the get-go uncomfortable. You all take care of sick patients, and not all of your procedures are with really sick patients, but some patients are just not surgical candidates. They're too sick for surgery. So they end up coming to your IP suite. And those patients are generally not great candidates for general anesthesia either. So that's just a burden and complexity that we face that we don't necessarily face in other situations where those patients probably just wouldn't make it necessarily to the OR. Sometimes we end up having to work in off-site locations. That's something that I really don't think any of your anesthesia colleagues are going to enjoy doing. Off-site locations have their own issues. This picture is of the new IP suite here at the University of Colorado, which is in the main ORs in the outpatient pavilion. But I have worked doing pulmonology procedures in off-site locations where I was working in a space that was not much bigger than a large closet that also had the anesthesia machine and all of your equipment. And it can be very crowded and difficult. If you need help, it can be difficult for people to find you. And it can be difficult to get the equipment and support that you need. So off-site locations and working outside of our usual haunt, which is the operating rooms, is something that anesthesiologists prefer not to do. Also, myself included, I had zero exposure for interventional pulmonology during my anesthesia residency. Dr. Shostak at Cornell University joined the faculty, the thoracic faculty there, after I had already completed residency and become a thoracic anesthesiologist. So during my residency, I worked solely with surgeons and didn't have any IP exposure, so I had to learn how to do anesthesia for these cases. As an attending anesthesiologist, I end up having other responsibilities. So if I'm covering an IP room, I might also be covering one or two other operating rooms, and so I cannot be in the room at all times. In these cases, things can change quickly, and so that's also something that is stressful that we don't particularly enjoy. There's a lot of potential for badness in some of these cases, and I know you all know that probably better than I. But when we, as anesthesiologists, if we're competent anesthesiologists, we're always thinking about the worst case scenario and then taking that to the worst case scenario, and what are we going to do to get ourselves out of that? So if we're prepared and ready, we've thought of all the horrible things that can happen so that if they do happen, we know how to get the patient through it. But there is potential for badness in a situation where we're in an offsite location with a sick patient and shared airway. You can see how that's something anesthesiologists aren't particularly looking forward to. Also, this is a picture here where we have an ENT surgeon and a thoracic surgeon who collaborate with Dr. Musani, and Chris, his fellow, is also in that picture. And those are great guys, but they're not always in the room. And if there really is something tragic that occurs and you need a surgeon stat, they may not be readily available. And anesthesiologists are most comfortable with, we train with, we work with surgeons. So that's, I think, a brief summary about why these procedures make us uncomfortable. And after telling you all of that, now you're probably thinking, well, do we really need you guys? Do we really need anesthesia? I mean, come on. But I think you all know, as opposed to straight pulmonologists who don't do advanced procedures like you all do, you probably do need us there. And as I think you will understand by the end of the talk, I actually am one of those anesthesiologists who really enjoys the stimulation and interest and challenge of anesthesia for IP procedures. So I'm going to convince you that I'm interested in IP. In 2016, I published this article with another thoracic anesthesiologist at Cornell and one of our IP docs, Dr. Shostak. And it's in the anesthesiology literature, and it really is an article that I wrote to sort of summarize the procedures so that anesthesiologists understand what you all are doing so that they can better plan for those procedures. And then last year, hopefully some of you were able to come to this talk. Dr. Sarkis gave a really great talk, as did Dr. Abdul Malak at this conference, which we really enjoyed. And Dr. Sarkis and I also wrote an article that's going to be coming out in next month in Medical Clinics of North America on preoperative pulmonary evaluation. And a lot of what I'm about to talk about is summarized in there. I'm going to bring this article up later, but it's also something, if you're interested in further reading, that I would refer you to, or anesthesia colleagues that you have. And finally, I'm giving this talk, okay? So hopefully you all are convinced that we're friends. And now we're going to talk about the basics of the pre-anesthesia evaluation. So I'm sort of going to structure this talk to include how we evaluate patients for all types of anesthesia, how we determine if they're ready to go to the OR, how we determine what medications to take, what testing to do, how we plan for procedures, and then I'm going to talk more specifically about how all this information is related in the context of IP procedures and the context of those underlying comorbidities that many of those patients have. So I just want to start out with a definition. So the ASA, the American Society of Anesthesiologists, published this practice advisory in 2012, which defined what the minimum requirements for pre-anesthesia evaluation are. So this statement really delineated what all anesthesiologists have to do prior to bringing a patient to the OR, but this is a real minimum requirement. This is what you will see your anesthesia colleagues performing when they see patients in the pre-op area. In our clinic and in your institutions where you may have a devoted preoperative clinic as well, in our clinic where we see patients 4 to 10 days prior to surgery, we do a much more in-depth management. But the basics of a pre-op eval done in the pre-op area would be a history and physical exam, which precedes ordering, requiring, or performance of specific pre-anesthesia tests, and consists of the evaluation of pertinent medical records, a patient interview, and a focused physical exam. So you're supposed to take a good history, do a good exam, determine if any tests are necessary to determine if the patient is ready to go for the OR. They define, I'm going to go over that in 1 second, sorry. So the goal of this pre-anesthesia evaluation from our perspective is to answer 2 questions. Is this patient optimized for their procedure? And what would be a safe plan for this patient for this procedure? So the first question, when we're evaluating the patient, examining the patient, and discussing the patient, looking at their labs and their test results, we're trying to see, is this patient optimized for the procedure? And if they are, if all their medical problems are well controlled and the patient are as controlled as they can be, and there's nothing else we can do to make that patient have a better baseline status so that they can have the best possible outcome from their surgery or procedure, we're going to just proceed. If they're not optimized, proceeding is going to depend upon how urgent or emergent the case is. For patients who are not optimized, so for example, the severe asthmatic who comes in actively wheezing, or a COPD patient who's having an exacerbation, or a brittle diabetic with a glucose of 400, if these patients are showing up for an elective procedure, they're going to probably be rescheduled. If they're coming for an urgent procedure and we have an hour or 2 hours or 3 hours to do something, we may be able to run a set of tests. We may be able to correct their glucose and make sure their potassium is okay. We may be able to manage them and improve their outcomes a little bit if we have a little bit of time. If it's a real emergent situation with a bleeding airway or a patient who's really decompensating, we're going to have to take them to the operating room or the pulmonology suite and deal with it in there, regardless of what we get when we get there. If we're not really sure and we have time, we'll get additional testing if we feel like it's indicated based on the physical exam and history. And the last point that I want to make here is that developing a safe plan for patients having IP procedures really, really requires a lot of communication between the IP docs and ourselves. Now, if you all work with a group of anesthesiologists that vary commonly and they know what you're planning on doing and you're doing something straightforward, You may not need to have a face-to-face discussion before bringing that patient back to the procedural suite, but if you're doing something you don't normally do with a doc that you work with frequently, then you should probably have a conversation with them. Or if you have an anesthesiologist that you've never met or seen before, it's a good idea to talk to them to make sure they know what your expectations are, and so that everyone's on the same page. So the exam that's required as to that ASA standard statement is a focused exam, which just requires a cardiopulmonary exam and an airway exam. I'm going to just take a couple minutes here just to briefly go through what a thorough airway evaluation entails. I know you guys probably assess airways fairly frequently, but I just wanted to indicate how an anesthesiologist will approach this. So the first is difficult ventilation. So this is pneumonic is obese here. So patients that are obese, bearded, edentulous, have severe sleep apnea, or our emergency cases are going to be patients that may be difficult to ventilate. They may be patients that we don't even attempt to ventilate. And that's going to be part of our induction and airway plan. Difficult intubations, there's a few different ways that we assess that. There's the Mullen-Potty classification, upper lip bite test, mouth opening, and thyromental distance. The Mullen-Potty classification, you guys have all probably seen this, or possibly you use this on a regular basis. It's really not very specific and not very sensitive, but typically a Mullen-Potty 1 is not going to be a difficult ventilation or a difficult intubation. Whether a 3 or 4 is going to be difficult, it's not that great for assessing that. Better sensitivity and specificity for difficult intubation can be found with the upper lip bite test, which isn't something that I was used to doing up until a couple of years ago. Really, we just ask patients to bite their upper lip with their lower teeth like a bulldog. If they're able to do that, that is pretty indicative of someone who's not going to be difficult to intubate. Someone like the patient over on the right, so C, is a patient who can't bite their upper lip and they can only move their lower teeth to be in plane with their upper teeth. And I don't know if you all are trying to do this yourselves right now, but I just did that on myself without thinking. But anyway, so the C's are people who have to who can't put their lower teeth in front of their upper teeth, and it's pretty specific for someone that might be difficult to intubate. Mouth opening is something I wanted to include just because this can impair your ability to do the procedure that you're planning. If someone has severe mandibular joint dysfunction for whatever reason, and they can't open their mouth, even paralysis may not be able to fix that. And these are patients that are probably going to be a difficult intubation and may not be great candidates for rigid bronchoscopy. Thyromental distance, this is a picture, is actually a before and after picture of someone with a chin implant, but I use it because I think it's a good indication of what is a so-called normal thyromental distance and what is a reduced thyromental distance. And the picture on the right, we can see that he has less than 2 finger breaths, and those patients typically have an anterior airway where when we look with a laryngoscope, we do not see cords. We may see arytenoids or just epiglottis. Other things to consider are the neck range of motion. This is something I really pay close attention to. Patients with cervical stenosis that have neck pain, numbness, or weakness with movement of their neck are not going to be able to tell us if they're experiencing those symptoms when they're under general anesthesia or paralyzed, and you can do damage to patients by hyperextending their necks. And I get particularly concerned with that when patients are undergoing a rigid bronchoscopy, that while they're asleep, they may undergo some permanent damage to their nerves. Any history of surgery or radiation or pathology of the oropharynx, larynx, trachea, or anterior mediastinal space is something that could portend a difficult intubation and or a difficult ventilation. So specific to patients having IP procedures, although these would be things that you would be concerned about in any patient, but some of your patients may be more likely to come with hoarseness, if they have a recurrent laryngeal nerve involvement with a mass leading to vocal cord paralysis. We get concerned that if we injure the other cord during intubation, they'll have a full airway obstruction and may need tracheostomy at the end of the procedure. Stridor, we get concerned of upper airway obstruction, including vocal cord paralysis. Patients who look like they're really struggling to breathe may quickly decompensate, and we want to consider if we want to keep them intubated and have them go to an ICU or step down for monitoring afterwards. Patients with dysphagia may be an aspiration risk. Many of your procedures, we use LMAs or rigid bronchoscopies, and those patients do not have secured airways. So it may be a consideration to first intubate them with an endotracheal tube and then aspirate their gastric contents before unsecuring the airway. Wheezing is something that should be treated prior to induction because bronchospasm always worsens once you start manipulating the airway. And patients with anterior mediastinal masses that are compressing the vessels or compressing the airway may not be able to lie flat. And so we want to look at that. And those are patients that we get really concerned about giving them paralysis. They may be patients that we end up intubating with an awake fiber optic, maintaining spontaneous ventilation, and having the patient seated upright. So again, I'm just going to refer you to the article. It's coming out next month. Dr. Musani edited, I think, the edition, and Dr. Sarkis and I wrote this article on preoperative pulmonary evaluation. If you email me, I'm glad to send you a copy of it. So you all, I'm sure, have routine pre-procedural tests that you order based on the procedure that you're doing or the pathology of the patient. But from an anesthesia perspective, what tests do I need for my patients before bringing them back for an interventional pulmonology procedure? And there actually is no routine testing that is necessary for these patients. Testing needs to be ordered based on medical history and physical exam findings. So patients with certain comorbidities may need additional laboratory or other testing, but just because a patient walked in the door and they're having an IP procedure doesn't mean they need any testing. So in our pre-op clinic, I devised this protocol. We use this to guide testing for patients having surgery. C surgeries are considered highly invasive. Those would be craniotomies or long spine cases, large abdominal tumor resections, and they get a lot of labs. But for everything else, labs are just based on medical conditions. So I would consider almost all IP procedures to be minimally invasive. Maybe you all have an opinion on that that you can share with me at the end, but I would call you guys all a magnitude A procedure, and labs would only be ordered based on the presence of renal disease, liver or pancreatic disease, the use of an anticoagulant medication, or the presence of diabetes or cocaine use. So how do we assess cardiovascular risk? There's 4 different main calculators. We typically use the NSQIP surgical risk calculator in our clinic. We perform that calculation for every patient that comes in, but the problem is this requires a CPT code for a surgery. And the Gupta risk calculator as well as the SURPASS calculator also require a CPT code for the surgery. All of these calculators have been validated in the surgical population. They're not validated for patients having interventional procedures. So the question is, can we use any of these to evaluate cardiac risk in your patients? Probably not. But I would probably say that what I would do is use the revised cardiac risk index to just get an idea of where that patient lies. You would not be performing any high-risk surgeries, but your patients may come in with any of these other risk factors, and depending on how many answers they have, they may have an elevated risk of MI or cardiac arrest following procedures. So this is a figure from that article that I referenced earlier, and it's basically just a distillation of the ACC-AHA guidelines from 2014, so the American College of Cardiology guidelines on perioperative cardiovascular examination. And it sort of indicates whether or not we need to do any testing. So patients with a low risk, we don't test. And patients with an elevated risk but can achieve greater than 4 METs without symptoms, we also don't test. And so it's the patients with an elevated risk with unknown or less than 4 METs, functional tolerance, that we may end up testing. But if you go ahead and have stress testing, you have to be prepared to follow up with intervention if necessary. So if you send a patient to stress testing, it's abnormal, they go for a cath, they end up getting a stent, they have at least 30 days of dual antiplatelet therapy that they're going to require. And so the question is, are we going to be postponing your procedure for at least 30 days? Is it worth it to reduce their risk of an MI, or are we really concerned about their disease process and waiting for them to have their procedure within 30 days? So if you're performing a procedure that absolutely should be performed within 30 days, you're not going to want to proceed with stress testing regardless of functional status and regardless of a patient having an elevated cardiac risk. How do we determine functional status? This is sort of the classic question that anesthesiologists will ask is, can you go up 2 flights of stairs without stopping to take a rest? Do you get shortness of breath or chest pain when you walk? How far can you walk on a flat surface without getting shortness of breath or chest pain? So we're trying to determine what their functional tolerance is. 1 MET is 3.5 milliliters of oxygen consumption per kilo per minute. 4 METs is basically what we consider patients need to be able to achieve before they undergo a general anesthetic. That's roughly about 15 mLs of oxygen consumption per kilo per minute. And you can see this compendium, which is kind of an old document, but was updated in 2000. You can sort of figure out how many METs someone can achieve based on what type of activity they do. But we've sort of turned in our clinic over to using the Duke Activity Score Index, or DAISY, and that's something a lot of other pre-op clinics are using as well. You have patients answer 12 questions. Oftentimes people just give them an iPad and the patients answer them themselves. And from their answers to those questions, you can usually determine what their risk is of how many METs they can obtain that way. And typically patients obtain more than 4 METs unless they have a dependent functional status. Other tests you might order: an echo based on exams or exam findings or history. Stress testing we already discussed. PFTs and x-rays you may get, we rarely get them. It's really only, we want to look at them and assess them, but we typically don't order them unless the patient's getting lung resection. They should definitely have one before that. So pulmonary complications happen just as frequently as cardiac complications. There's 4 different risk indices. They're all listed here, and the factors are listed as well. Problem with these risk indices is that, again, they used the NSQIP database. They used surgical database to determine risk factors. So the question is whether or not they're useful at all for your procedures. So I don't typically perform them for IP patients. Medication management, I just want to talk about real quick. According to CMS guidelines, if an RN calls and tells a patient to interrupt prescribed medical therapy before they have a procedure, then they need to have a doctor's order for that. So I put together a protocol instructing nurses to tell patients how to interrupt their therapy. This is the document that we developed. So one thing to talk about for antihypertensives, which is kind of controversial right now, is ACE inhibitors and ARBs. Typically we tell people to hold them, but if someone has poorly controlled hypertension, we may have them continue. If your renin-angiotensin system is blocked and you have a sympathectomy of a general anesthetic, they can end up having a profound hypotension, which requires vasopressin to get out of. So that's why we typically have them hold them unless they're difficult to control. Hypoglycemic agents, something you want to make sure you intervene on in patients with diabetes who are about to be NPO. We put together this whole chart of all these different medications to guide that, and we have them check the glucose before coming in. And one thing I just wanted to spend a minute talking about is aspirin. I don't know if you all are aware, but patients with coronary stents of any age, regardless of type, should continue baby aspirin, at least low-dose aspirin, perioperatively unless absolutely contraindicated by the surgeon or proceduralist. Patients who are on low-dose aspirin and have coronary stents who interrupt therapy before a procedure have a 40-fold increased risk of perioperative MI. So I find from a lot of surgeons' offices, a lot of gastroenterologists will just tell patients, stop your aspirin 10 days before, without really having a regard of what the indication is. And it's not really the docs who are telling the patients, it's their RNs or their MAs who are routinely telling them based on a protocol. So what I encourage all of you to think about is, can you divide up your procedures into 3 buckets? so that patients who really should have aspirin can continue it if it's appropriate. So if you have a low bleeding risk procedure, that would be a procedure where people can continue their aspirin regardless of their indication. If it's an intermediate risk procedure, you're concerned about bleeding. So patients who don't have a compelling reason to continue aspirin should discontinue, but patients with coronary stents should continue. And high-risk patients, these are patients where they're going to need to discontinue regardless of the presence of coronary stents. So in the surgical population, the high-risk patients is really just for us. It's the craniotomies. Spine surgeries and almost all other surgeries end up continuing baby aspirin if the patients have coronary stents. We also manage antithrombotic agents based on surgical bleeding risk and individual patient-specific risk of VTE. So we may discuss with you all how high of a risk of bleeding is this procedure to determine how long to have patients off of their Eliquis, and try to balance that with their individual risk of having a PE or a stroke. Other medications that you may see in your patients are, oftentimes patients are on inhalers. We definitely want them to continue those. Patients with pulmonary hypertension taking any type of medication for that should not interrupt or discontinue that regimen. They need to continue that as well. Systemic steroids, they should take on the day of surgery. It's kind of controversial, but I would say there's not really any evidence to support that you should stress dose IP patients. They're not undergoing a moderate or high risk surgery. So even if they're on high dose steroids, having general anesthesia, they probably do not need to stress. Oral theophylline, I'm not really sure I've seen a patient on this. I think maybe once in the last 5 years. There are interactions with anesthesia which are problematic, and toxicity issues, so we have them hold that for at least 24 hours. These are NPO guidelines that I just wanted to share with you. We do have patients stop eating at midnight just because we had so many case cancellations based on patients eating something in the morning, and then they end up having a light snack and thinking that a breakfast burrito counts, and then they need 8 hours before their procedure. So we have them fast after midnight. And have clear liquids up until 2 hours before they get here, so that when they get to the hospital, they're meeting NPO requirements to proceed with anesthesia. These are the ASA minimum fasting guidelines. These are for patients without concern of gastroparesis, and these are the ones that the anesthesiologist will abide by unless the surgery or procedure has to be considered emergent to proceed without meeting these NPO minimum fasting times. All right, so we're in the IP suite together. We've decided we're going to do a procedure. What do I need to know from you before we start? First thing we like to know is, what is your plan for the procedure? What exactly are you going to do? It may seem obvious to you. I do look at your note. I do look at the scan, but I may not know exactly what you're planning and what you're concerned about. So having that conversation, unless it's a diagnostic bronch or an EBUS or something that's really straightforward, having a discussion is really important to help me understand what you're planning on doing. I also want to know, how long is this going to take? That's going to affect the medications I give. That's going to affect how much medication I give. And if we have a patient that's a really sick patient that may not tolerate a long anesthetic, we may discuss, hey, can we do this in a staged procedure? I'm really concerned about this patient having a long anesthetic. So the length of the procedure is also important. What is required? So what do you need from us? Do you need paralysis? Do you need jet ventilation? Do you need low FiO2? Do you need an LMA? So we will want to discuss all that, and you can let us know, and we'll have that discussion so we have everything in the room and we're ready to go. Want to contrast that with, what do you prefer? So there may be a specific type of LMA that you like, but the patient's a big aspiration risk, and if we can use a tube, that's much better. So we need to sort of differentiate between your requirements versus your preference. We always want to accommodate the preferences, but we may have considerations that aren't necessarily your considerations that mean that we have to negotiate a plan that's best for the patient. I want to know, what are you worried about? Is there something with this procedure you're specifically worried about? Are you worried about the airway collapsing? Are you worried about bleeding? What exactly are you worried about? If we know that, then we can both come up with a plan together to make sure we're prepared and ready. What's our backup plan if there's extreme badness? So what are we going to do for this patient if we have severe bleeding? Do we need a bronchial blocker? Do we need a double lumen tube? Do we need a surgeon? What are we going to do for that? Should we have blood in the room? So those are things that we should discuss to come up with a good plan. So now I'm going to just go through the different stages of planning that we sort of think through while we're developing an anesthetic. There's 3 slides here that I'm going to go over, and it's gonna sort of frame it in from an IP perspective. So goals of care, I wanted to start with this. There is some misconception that patients with DNRs, we used to just rescind them, and that was that. You have a DNR, your DNR is getting rescinded, we will reinstate it when you've recovered from the procedure. Done. But actually, that actually goes against the patient's right to autonomy as a patient, and we should be honoring their wishes even if they have a DNR. So we should have a goals of care discussion with the patient, which may mean that we end up continuing the DNR in the OR. But usually what happens is we have a conversation with the patient, we talk about what the likelihood of recovery is from anticipated events such as hypotension, which you're going to treat with a vasopressor, or continued intubation after you place an endotracheal tube. Those are things that you may anticipate and discuss that the patient may agree to. But if there's an unanticipated arrest or an event where the patient requires CPR or something really heroic, many patients that are DNR just don't want it taken to that stage, and I will honor that wish, and we fill out a limited resuscitation form and are very specific about what the patient does want. Whenever you're thinking, and I know this happens very rarely, but the 1 or 2 cases that we've had where we've decided to have ECMO as a backup or actually use VV ECMO to get through the procedure, you definitely do not want to do that in a DNR patient because you're never going to get them off of that. Next thing we want to talk about together is, where is the safe location to have this? Like I said before, we never want to be in an off-site location. Many of us would rather not be in a freestanding facility either. An outpatient OR is probably more along our lines, but it really has to do with whether or not we think this is straightforward, how sick is the patient, what's the chance that we're going to need help, do I need extra equipment, is there enough space to find a place that's going to be safe. I think it's better not to relocate surgeons, pulmonologists from where they're used to doing their procedures, because that gets them in areas where they may not have the equipment they need or the nurses that are trained in the way that they need. But if there's a compelling reason for patient safety, we will move them. Monitoring and access of standard ASA monitors are EKG, pulse ox, blood pressure, end-tidal CO2. We got to have those. We may need an arterial line. We may need a central line or a swan. We may do a processed EEG if we're worried about awareness, especially in a patient that we're running an IV anesthetic who's paralyzed. Inductional plans or that we're going to think about awake fiber optic. I mentioned that earlier. An inhalational induction if we're worried about paralysis and we want to keep a patient spontaneously breathing. Intravenous induction, and a rapid sequence induction if we're concerned about aspiration. If a patient has a mass that's compressing or vascular involvement, the patient's unable to cooperate, if a patient likely has neuromuscular disease or has an airway that is going to be easily compressed once the chest wall is no longer rigid, then that's all going to impart our information for our planning. Airway management is, again, a big thing that we'll have to discuss together to come up with a safe plan. There's lots of different things, heliacs, jet ventilation, tracheostomy. If you're expecting those things and you're working with someone who's not always in there, is something that you want to discuss so that they have everything they need and they're prepared to proceed for your surgery. For masses and compression, we worry about hyperdynamic inflation. Many of those compressions tolerate insufflation with positive pressure. ventilation, but passive expiration does not occur and they can get hyperdynamic inflation. We get worried about airway fires, so we may need a mixer to make sure we can give a lower FiO2 through a jet ventilator if necessary. Maintenance of anesthesia, these are all the things that we're thinking about. Our plan for extubation we'll discuss together, and our plan for disposition will really do with how the patient does during the procedure, their tolerance, their comorbidities, and what we needed to use to get them through it. So Dr. Abdulmalak put together these two articles, one from 2012 and one from 2014. I don't have a ton of time left, so I would refer you to these. These are really great synopses of anesthesia considerations for these specific procedures. This is more of an intra-op type of thinking, but I wanted to include this just to be comprehensive. These are some of the things we think these are non-urgent, more elective procedures that we may be doing together. So these would be patients that we probably want to make sure that they're optimized. And these are some of the concerns that we worry about with these procedures. This is not really a comprehensive list. I'm sure you guys have a lot of other procedures that you're doing. It seems like there's always something new too. With electromagnetic navigation, we will need special non-magnetic equipment, and that can interfere with some of our monitoring. So that's something that needs to be sort of set up for and planned for in advance. Bronchial thermoplasty is a case that actually we were planning to do at Cornell, but I never had done any of those cases. I don't know how commonly they're done, but we get really concerned about those patients because they seem to get worse before they get better. So the other types of cases that you all do, which is urgent or emergent cases, including bleeding airways, obstructive tumors, compressive masses, are really challenging. Emergent cases are challenging to begin with. These patients usually don't meet NPO requirements. We have to plan for their anesthetics under pressure with limited time to research their history, and we don't have time to optimize. We just get what we get. And we may end up actively resuscitating this patient while sharing the airway. These are likely cases where we're going to need more than one set of hands on the anesthesia side, making sure that we get the patient through the procedure. Mediastinal and central airway masses are not always emergencies, but I always find them interesting and always challenging. They're always a little bit different based on where they're located and what they're compressing and what they're doing. The patient's condition can be something that sort of rapidly declined, or it can be something where it's sort of been a slow thing that they've finally getting biopsied. Mediastinal masses, we get concerned about neuromuscular blockade, vascular involvement, and airway compression. So these are just a few pictures of different masses in the central airways. Those are also interesting because we got to come up with a plan where we're going to be able to ventilate these patients, secure the airway however we can, and get you guys through the procedure. So I find those cases interesting. Anyway, so that's the end of the talk. Hopefully we have time for some questions, and I just wanted to say thank you to all of these wonderful people, many of whom you all know, for giving me the opportunity to speak here, and also for being wonderful colleagues in this adventure with us. So for the end of the rest of the time we have, I'm available to answer any questions if you all have any.
Awesome. Thank you, Dr. Selzer, for really a nice and effective overview of the anesthesiologist's perspective of preparing for these IP bronchoscopies. A really, really nice and effective talk, I thought. So for the audience, we're going to go into the Q&A period now. Just for those who joined us late or missed the opening intro, please type in any questions into the chat box that can be accessed in the toolbar at the bottom of your screen. While we're waiting, it looks like we have a couple questions while we're waiting for maybe one or two more, Dr. Selzer. Let me just get things going. As you effectively conveyed in your opening slide, there's justified wariness of IP procedures from the anesthesiologist perspective. You stress the importance of communication and the consistency of exposure to these cases in optimizing outcomes. I'm curious if your institution has a core group of anesthesiologists that get assigned to IP procedures, if this is a feasible or common model in the anesthesia world, and if so, how an interventional pulmonologist may work with their anesthesia department in arranging such a structure at their respective institutions?
Okay, yeah, that's a great question. So I just came to this hospital about a year and a half ago. I was at Cornell University in New York City before that, and things are done differently. So I can just speak to the two institutions that we have here that I have experience with. At Cornell, for the most part, thoracic anesthesiologists did the IP cases. Dr. Shostak was appointed within the Department of Thoracic Surgery. And his OR time was in the thoracic ORs. So for the most part, and things may have definitely changed since then, but for the most part, we did those procedures when every once in a while, when one of us was not available, say after hours or on the weekend, someone else would do them. And here at this institution, there are people that are on a special list of people who are interested in doing advanced airway cases. So not only IP procedures, but a lot of the head and neck surgeries as well require jet ventilation and fiber optic intubation. And anesthesiologists who are comfortable with that are likely going to be more likely to be comfortable with IP anesthesia as well. So that might be a place to start if there's sort of a difficult airway group within the Department of Anesthesia. You might want to pool that group to see if you can consistently get those in your OR. So here that's a larger group. There's probably 12 to 15 of us that get assigned to the IP cases. And as someone who's primarily in the pre-op clinic, I don't get to do these cases as much as I would really like to, unfortunately, because there's many of them that do them, and I'm down in clinic quite often.
Okay, awesome. Good tips. Looks like a couple of people are interested in conventional versus jet ventilation. Is one better for certain scenarios, and do you personally have a preference?
It depends on the type of procedure. I'm always going to prefer conventional ventilation. So if we can accomplish the procedure without jet ventilation, that is always going to be my preference. But, sometimes we can't accomplish the procedure without jet ventilation. The issues with jet ventilation, I'm glad this question came up because I did not mention it at all, was hypercarbia. With jet ventilation, we have issues with just getting enough CO2 off. So while we're jet ventilating, we may be delivering adequate amounts of oxygen to oxygenate the patient, but these patients may end up getting profoundly hypercarbic as we just aren't getting as we're reliant on passive expiration to release the carbon dioxide. Oftentimes we end up with hypercarbia. And when you take that in the setting of lung disease in patients who probably have some degree of pulmonary hypertension, and then you make them hypercarbic, I would prefer not to use jet ventilation whenever possible. Another opportunity is the high frequency jet ventilation, and that's something that I know some institutions use. But it's not something that I actually have any experience with. And I believe that can keep them from getting quite as hypercarbic as they do with the traditional jet ventilation. Okay. One other thing to think about just with the jet ventilation that we concern about, especially with airway masses, is where you have a situation where you're able to, under high pressure, deliver oxygen beyond a compression or a mass, and then that they're unable to passively expire, and they end up air trapping, and we get hyperventilation. I've seen tension pneumothorax from that.
Great. Staying on that topic, do you think the jet ventilator, for example, the monsoon system, confers any advantage over the manual jet?
Yeah, so that's the monsoon system, is that high frequency jet ventilator that I have zero experience with. Neither at University of Colorado or at Cornell University did we actually have one of those. I know my colleagues at Sloan Kettering use them and really like them, but it's not something I have any experience with. I do believe that it delivers the breath with less of a high pressure, so a little bit less of a concern of that air trapping, and I do believe it does a little bit of a better job preventing hypercarbia, because I know some patients end up on the monsoon for some cases for hours and hours and do okay.
Great. We have a question about paralysis. What is your opinion on its effects on specifically IP procedures? And are there any circumstances when its use is preferred or better avoided?
Okay. Yeah, thank you. I also didn't get a chance to talk about that, so I'm glad there was a question. Paralysis, and there's a few there. You're going to see anesthesiologists doing these cases. There's going to be two discrete camps. There are the Lannisters. Those are the guys that don't like paralysis at all. And then there's the Starks. They always paralyze. So I'm a Stark. I love to paralyze my patients. I do not want my patients bucking. It makes me really nervous to have, sharp metal objects in the airway in a non-paralyzed patient. Some people just do all of their cases without paralysis completely. That's their style. They're very comfortable with it. They have great outcomes with it. So it's hard to say that that's a problem, but for myself personally, I always prefer paralysis. There are patients, however, anterior mediastinal masses, myasthenic patients where you're concerned that paralysis is going to lead to complete loss of the airway. And in those patients, they're reliant upon their chest wall rigidity to keep their airway open. And so they may require no paralysis at all. And for those patients, I typically do an inhaled induction and keep them on a volatile maintenance instead of an IV maintenance to keep them breathing spontaneously. The other thing to think about with paralysis, as long as your IP doc is in the room and they're ready to proceed with rigid bronch right away if necessary, then your concern about really collapsing the airway with paralysis is less of a deal. And so as long as you're all ready and prepared, but you do get concerned with anterior mediastinal masses in particular.
Awesome, thank you. Another conundrum we frequently encounter in our patient population is TE fistula. Do you have any advice or strategies to avoid gastric insufflation in patients undergoing airway intervention for these individuals, whether it's with positive pressure ventilation or with jet?
Yeah, the sooner you guys fix the fistula, the better it is for us. Is what I would say. But I think that that's a patient that if you can keep them spontaneously ventilating so that you're avoiding positive pressure ventilation altogether, then that's preferred if possible. If you cannot do that and you need to take over ventilation, it may be a situation where you advance the tube under a fiber optic scope to be distal to the fistula so you can ventilate them until you guys are all ready to do your procedure, and then we can remove the tube or pull the tube back. So noting where the fistula is important. If it's proximal enough, you can place an endotracheal tube distal to it. Being careful not to increase the size of the fistula if you're too close, your balloon is too close to it. But really it's keeping them spontaneously breathing and minimizing the amount of pressure you use and the duration of positive pressure ventilation.
Great. Another conundrum that comes up in our patient population is the use of ECMO. Do you, obviously pursuing this approach is very individualized and lots of factors contribute to the decisions to proceed. But again, I'm curious from an anesthesiologist perspective, are there specific circumstances in which you are suggesting to your proceduralist to seriously consider this approach?
Yeah, I've had a couple of cases where I've suggested ECMO, and specifically I'm interested in VV ECMO. Most of the patients do not require cardiopulmonary bypass. They just need the VV ECMO so that they can have oxygenation and ventilation taken over for them. And I've done one case. It was actually a 14-hour case with a thoracic surgeon with a really decimated airway, unfortunately, that allowed him to operate for that duration of the time, and the patient was very stable and did very well. That patient ended up having a withdrawal of care, and getting that patient off the ECMO was a real big problem. So I think having specific patients that it meets with their goal of care, that they have a situation where they're going to need very prolonged periods of apnea in order for you all to do what you need to do, and they may not be able to tolerate that. The VV ECMO may be a good alternative, but you want to be wary of pulling out that card unless you feel like that patient can definitely, absolutely have a full recovery from their procedure or surgery.
Really good tip. Looks like we have time for one more question. It looks like, again, Dr. Ong. Are there any issues for or against the use of paralytics in patients ventilated using just an LMA, an iGel tube?
I will use paralytics with an LMA for sure. The issue with an LMA is that you don't always get the greatest seal. And so the best way to use an LMA is to keep a patient spontaneously breathing and have sort of pressure support. That's where the LMA is the best used. When you start doing positive pressure ventilation with an LMA, if you don't have a great seal, oftentimes you can lose quite a bit of tidal volume that way. Once you paralyze the patient, you're dependent upon positive pressure ventilation. So you just need to make sure that you have a well-seated, well-functioning LMA.
Perfect. Perfect. Okay, I think we're probably about out of time. Thank you, everyone. That was, I think, went really smoothly, and audience asking really good questions. And of course, thank you once again, Dr. Selzer, for a super talk. I'm going to turn the mic back over to Dr. Shah for final announcements and closing the webinar.
Thank you, Ara. And again, thanks to Dr. Selzer. I would have to echo everything that Dr. Christian mentioned about the applicability and the value of sharing your thoughts as to how you view our patients that we're mutually taking care of. By way of announcements, you can see on your screen the upcoming webinar schedule. This is tentative, as you all know, but as usual, if there's any comments, suggestions, please forward them to Ara and myself. They are very helpful for us in how we shape the webinar series. Similarly, if you hear of any individuals who had any experiences that we can do to, anything we can learn from as we're transitioning to the Zoom platform, either difficulties or problems, please forward that to Ara and myself, and we'll try to work to smooth out the transition process as best as possible. So with that, thank you everyone for joining us. Thank you, Dr. Selzer, again, and I hope you all have a great evening.
Thanks so much for having me, and for everybody that took some time tonight to join this webinar. I really appreciate it.